Welcome to the podcast of HemaSphere, the official journal of the European Hematology Association. HemaSphere's podcast presents insightful, expert discussions about recent hematology publications. We hope you enjoy.
Hello and welcome to the HemaSphere podcast. My name is Charles de Bock and I'm your host. Back in April 2012, Emily Whitehead made history in being the first pediatric patient with B-ALL to receive a CD19 CAR-T therapy. Since then, immune therapies have really revolutionized how we treat B-ALL. However, what's talked a little bit less are some of the toxicities associated with CAR-T therapy. And even Emily Whitehead developed severe cytokine release syndrome and acute respiratory distress syndrome as side effects that was addressed with tocilizumab. What is now becoming apparent are additional hematological toxicities, which include immune effector cell-associated neurotoxicity syndrome, or also known as ICANS, and long-lasting cytopenias. Whilst these hematological toxicities are common, their underlying pathophysiology is not completely understood, and how they are managed is not well defined either. So I'm really delighted today to be joined by Kai Rejeski from the Department of Medicine, Hematology Oncology from the University Hospital LMU Munich, Germany, who is the first author on a paper published in 2023 in HemaSphere entitled An International Survey on Grading, Diagnosis and Management of Immune Effector Cell-Associated Hematoxicity Following CAR-T Therapy on behalf of the EBMT and EHA. And the reason we're talking about this paper today was that it was awarded the HemaSphere Most Cited Clinical Article at this year's EHA Congress in Milan. So first of all, Kai, welcome and congratulations. And I'm looking forward to dig a bit deeper into this paper.
Thank you so much. It was really an honor to receive the award, also on behalf of all the co-authors that were involved in this project.
Excellent. So I'm going to start off by asking about side effects to cancer therapies, which are not new at all. And in the paper, you also refer to the toxicities seen in CAR-T therapy as an old new kid on the block. So perhaps you can elaborate on that concept and what makes side effects from adoptive cell therapies so unique.
So I think you just alluded to Emily Whitehead, right? And so one of the first side effects that was described was CRS. So this sort of syndrome of fever, respiratory distress, cardiovascular insufficiency. And I think the first thing to sort of highlight is that the symptoms of yesterday are really the syndromes of tomorrow. So when CRS first came on the scene, it was a new kid on the block. It was some syndrome that hadn't been described previously. And so investigators gave it a name, and that really set the stage for developing consensus-based grading system as well as clear treatment recommendations. Similarly, ICANS wasn't ICANS. It was sort of this variety of encephalopathic symptoms that were then combined into this very uniform grading system. Now, Emily Whitehead actually is not just characterized by being sort of a pioneer as a young patient, one of the first to receive CAR T-cell therapy, but she actually also has a recurrent infectious complications. And I think that this is really something to underline, that as we're getting further along in the sort of survivorship phase of CAR T-cell therapy, we now have patients that have been treated for more than 5 years or even a decade ago. We're now learning a lot about the types of side effects that are more long-lasting, that can impact morbidity, patient quality of life, sort of more in the long-term period. And certainly, cytopenias are one of these. Infections are really a very important one as well. And these two are actually quite linked to each other. Other side effects that I think we've grown to appreciate in the last years are also secondary malignancies that I think we have to be on the lookout for. But yes, cytopenias certainly are sort of the new kid, or an old new kid on the block, in the sense that cytopenias are some of the most well-described and earliest side effects of cancer treatments, described by Goodman and colleagues more than 70 years ago. And so they're certainly not a new kid on the block, but they're clinically relevant and they're very frequent in CAR T-cell recipients. And so that really set the stage for this effort to really try to understand management better and to give this specific side effect a name as well.
Okay. What's interesting as well is I think in terms of the side effects like the cytokine release syndrome, that also is an indicator that the CAR-T therapy is actually working, right? I think I remember going to a seminar by Carl Jun and saying, when they first gave those CAR-T cell therapies, when they saw that, they went, actually, the reason that's happening is because this massive tumor lysis, right, which is happening, which is good. But then they underestimated how to manage that at the time. So it's kind of interesting, as you say, over the long term, how the side effect profile is becoming more defined and the implications for that. And so
it's definitely true. There's levels to this, right? There's basically, we start off with understanding sort of the first side effects that are sort of observed. We grade them, we try to manage them well. And as we're getting further along, we're getting much more granular in our description of the side effects that occur because we just have a much larger evidence base. If a side effect only occurs in 2% of patients, you need to treat 50 patients to observe it once, right? And so even rarer side effects, that becomes much more of an issue, right?
Yep. And so for this paper, you carried out this multi-center international survey across 72 centers in 18 countries, of which Australia was one, which was kind of nice to see on the list there. And I know that these are never easy to undertake. And so can you share some of the logistical challenges in coordinating the responses and consolidating those diverse opinions on grading and management into some sort of coherent data analysis? I can imagine that there are not only just ways of treating, but geographical and cultural differences as well, which might be reflected in that data. So what was your experience like in trying to manage this mammoth effort?
Absolutely. So as you mentioned, more than 72 centers participated and in 18 countries and actually 4 continents. And so we're actually very proud of this fact and hope that this increases the scope and the robustness of these results moving forward. And I'll just highlight that such a massive effort would not have been possible without institutional support from both the EBMT and the European Hematology Association, so EHA. And I think that that's really something to highlight. These types of efforts, you can try to embark on them by yourself, but there's a lot of logistical aspects behind this. And so really we leaned into the EBMT Practice Harmonization and Guidelines Committee under the leadership of Ibrahim Yaqub Aga, who's now actually the president of EBMT, who really has worked on these types of questionnaires previously. And so we had sort of the network in place to, once we have a good question database, to really reach out to stakeholders across different countries, to reach out to those centers and to get those responses that we needed to really drive this forward. I'll also just highlight that from the get-go, that was sort of the planned goal of developing sort of a consensus framework. So this questionnaire really was the basis for then thinking about how can we grade this side effect? Do we need to sort of give it a name, provide a grading, provide treatment recommendations? And so from the get-go, we really were anticipating that there's some degree of heterogeneity. And this heterogeneity is actually strength in this type of analysis because you can glean from it just variance in management practices. And I think if you find 100% consensus, you don't need to address it. You don't have a problem, right?
Yes.
So if you find that there is a high degree of variance in sort of answers and management practices, that actually is a good indicator that you're onto something that may need to be improved. That is certainly what we saw here.
I never thought of it in that way, actually, but yeah, that's a really good point to make, that the fact that there is so much variance is the very reason why to undertake these mammoth efforts. If I just want to dig a little bit into some of the findings that you had, you found that hematological toxicity was initially underreported in terms of clinical significance, despite representing the most frequent grade 3 and above toxicity after CAR-T. Why do you think that this crucial side effect was overlooked or underestimated initially, particularly when compared to the more widely recognized cytokine release syndrome and ICANS, for example? Was it a numbers thing?
So I don't think it's a numbers thing because in this sense, it's actually the most frequent grade 3 or higher side effect. So it was there in front of our eyes. The thing is, it was, on the one hand, it was attributed to the lymphodepleting chemotherapy that was applied before. And so our clinical grading systems in clinical trials, they account for the depth of cytopenia. So once you hit a certain threshold, that's capped. And so you can say, for example, 70% developed grade 3 neutropenia. But that really doesn't quite get at the clinical relevance yet because you could have a one-time measurement of an ANC less than 500, or you could have a measurement over 2 weeks. Now, if it occurs within the first week in close proximity to the lymphodepleting chemotherapy, you can say, sure, well, that's just a side effect of the lymphodepleting chemotherapy. But around 2018 to 2021, there was just increasing evidence and analyses that were really highlighting that cytopenias are not only frequent, they are actually protracted. So patients can, have more than 7 days of severe neutropenia, so an ANC less than 500. Some even have profound neutropenia, so an ANC less than 100. And actually, in a data set that we published in Blood in 2021, we were able to show that about 2/3 of lymphoma patients had neutropenia beyond day 21, clinically significant neutropenia. And so I think that was sort of it was there, and it was there in sort of plain daylight. It was attributed to the lymphodepleting chemotherapy. Certainly the chemotherapy plays a role, but I think that was perhaps underestimated in terms of its clinical significance. The second thing that I just mentioned, sort of alludes to what I was mentioning before, is that again, CRS and ICANS, new kids on the block, right? They're the cool kid wearing the leather jacket, right? It's not this cytopenias is sort of the nerd that's in the corner, right? It's it's very well described. It's a side effect that is clinically relevant, but it's not something that's particularly novel, to be honest. As I mentioned, it's a very well characterized side effect for a lot of sort of anti-neoplastic treatments. And so both cytopenias and infections, I think, perhaps were underestimated initially because our eyes were glued on sort of CRS and ICANS as these novel, prototypical, class-specific side effects that hadn't been observed with other treatment modalities in the same degree. And so I think that also plays a role, or I think that those would be the two main reasons why I think hematological toxicity perhaps was not sort of a light shown as brightly on these sides.
It kind of makes me think that when you first see cytopenias, it wasn't going to break the internet, so to speak, when it came out and say, oh, no, we've seen this before. We don't need to address this. And it was underappreciated. And I think one of the nice things in your paper is there are so many nice figures which really illustrate how varied the approaches are in managing the toxicities. And one of the examples is that you found hesitancy among clinicians to apply early GCSF due to concerns about exacerbating neurotoxicities. And that was even despite, I guess, the recent evidence pointing towards that there is an acceptable safety profile there. And I guess the question is how challenging is it in the field to shift ingrained practices and beliefs, even when there's evolving evidence? And the concept of experience bias. So, for example, you're a new clinician and you're treating your first cohort of patients. Your first patient is the one that gets this terrible, terrible side effect when you give GCSF. And so you have that even in the evidence suggesting that you've got this experience bias, which suggests, no, I have seen how bad this can be. How do we overcome that? Yeah.
Yeah. I think that it's all about objective appraisal of data. I think that's a guiding light, a guiding principle. And so there's very clear sort of ideas as to sort of how to attribute data and evidence. There's different evidence grades. And I think that can oftentimes help. I think in this case, this is not an area where there was hard evidence. And we're actually in a situation where you're sort of guided by clinical gestalt and you're sort of trying to do the best by your patients. You may have seen that a patient in a different disease context, sort of a hyperinflammatory response is exacerbated by growth factors. So that's a ground hypothesis that you have even in the absence of data. And a lot of times we're talking about evidence-free zones where not a lot of patients have been treated. Now, one of the issues though that we have then is that once a clinical practice is ingrained, physicians do it. It's done in different and diverse settings. And so it can be really, really difficult to actually understand and discern if there's actually a treatment effect or a side effect is directly attributable to, for example, some type of supportive measure. Because what actually happens is that you end up, like if you do a retrospective analysis and you analyze sort of the impact of GCSF in CAR T-cell recipients, you'll find that the patients that have the most severe neutropenia receive GCSF. So your first association is patients that receive GCSF have worse hematotoxicity. But that's hindsight bias because you are only giving GCSF in the patients that had severe enough hematological toxicity to warrant administration of GCSF. And so it becomes really difficult specific centers will always defer GCSF. And there was some initial rationale to this as well. There's murine studies that highlighted that at least in a mouse model, the application of GM-CSF, which is not GCSF, is also a growth factor, was associated with sort of at least hints of increased neurotoxicity. And so that obviously is something that you don't want to exacerbate in a patient receiving CAR T-cell therapy. And so that I think really was the background for this. And at least in the studies that had sort of questioned this and basically provided GCSF in a prospective manner, the side effect profile at the time of when we at least wrote the consensus guidelines, which is the follow-up paper to this, really highlighted that there is at least not a signal towards increased ICANS or CRS severity. If at all, it's perhaps a little bit more moderate CRS, and that really is at the cost of having longer periods of neutropenia, which we now know, and this is really important, I think, also for the audience to drive down this point. CAR T-cell patients, the main cause of non-relapse mortality in CAR T-cell recipients are infections. So we just published a meta-analysis in Nature Medicine last year where we demonstrated that if you sort of looking at all clinical trials, real-world studies, more than 50% of all NRM deaths, so non-relapse deaths, are attributable to infectious causes. Whereas these sort of prototypical side effects like CRS and ICANS or HLH, which is sort of a sort of rare manifestation of the hyperinflammatory response to CAR T, they are observed in about 10 to 12%. And so I think under that aspect, finding ways to mitigate infection-related mortality is paramount. And so you're weighing two aspects here. On the one hand, even if you posit that there is increased inflammatory mediated stress, it may still be an advantage to sort of shorten the time period of critical neutropenia. And so I guess my point here is we now have some evidence showing that at least there is clinical safety and feasibility of this effort. Now that's a starting point. That doesn't mean that we've definitively proven anything yet, because what we need is prospective evidence. That's the highest degree of evidence that we can generate. And I would encourage moving forward that we try to approach this question in an evidence-based manner, that we really get at the heart of it, and that we sort of try to move from abstraction from other clinical contexts or clinical gestalt to actually moving to sort of hard data. I think that that's going to be hopefully a next step also from the survey where we really highlighted that heterogeneity in management practice.
Again, I think it's great. The fact that there is disagreement or there's lack of evidence suggests that here is a place where we need to actually put more money into to find out what the best way it is in terms of administering GCSF, etc. The next question is that the survey revealed that for neutropenia, the most common strategy, and this is again similar to this immune boost, is to give it autologous hematopoietic cell boost. What might seem a contradiction was that the prophylactic collection of CD34 positive cells before CAR T infusion was only done in about 10% of the cases. So, and you speculate that the reason why that is that 2/3 would probably consider that, but then don't do it anyway. Is that because of cost or logistics? And since that time you've published this paper, have you followed up and have you seen a kind of an uptick in the number of clinicians who preemptively collect these CD34 positive cells for the cell boost?
I think it's important to emphasize that it's not the most common strategy. The most common strategy is growth factor support. But in very severe cases, it's probably the most effective strategy. So that is something that we've learned. We've learned that patients that have, so first of all, what are we talking about here? So what we're talking about here is that we have patients, for example, multiple myeloma or B-cell lymphoma, that have in prior treatment lines received an autologous stem cell transplantation, which in many cases was sort of the previous standard of care. And so we then go back in time to see if we collected a second bag of these autologous stem cells, and then we apply the patient's own autologous stem cells to sort of rescue a patient that develops very, very severe hematologic toxicity. Now, if you sort of deconstruct that, what are the criteria that you need? So the first is you need to have a patient that, has received a prior autologous stem cell transplantation. Now, 4 years ago, when we were treating lymphoma patients, that was often the case because CAR T cells sort of was in the third line, but the ZUMA-7 trial and Transcend trial have now questioned this, and now in randomized comparisons, CAR T cell therapy has been demonstrated to be superior, providing sort of even an overall survival benefit. And so, at least in the lymphoma setting, this is not going to be a scenario that occurs anymore because we don't provide autologous stem cell transplantation in many cases prior to CAR T cell therapy. Myeloma, that's a bit of a different story because at least for younger transplant eligible patients, which again is not the whole population of myeloma patients who end up getting CAR T cell therapy, but transplant eligible patients, they might still have that second bag. And so at least in multiple myeloma, I do think that there has been a push towards really thinking about early application of stem cells when they're available. I think that has certainly been a change of thought based on some results that came out in the last 3 years or so and recommended in our consensus document as well. Then the next question then is prophylactic collection. So that's before what we're talking about. We have a bag. It's in our back pocket. And now a patient is developing cytopenia and we're applying this bag. The question there really is, when do we do it? Like, what is the trigger? Because, if a patient is cytopenic for 5 days, they may just recover their counts. You don't need to give that boost. That may be sort of a little bit of an over treatment. There may be actually some off-target side effects as well, some recent evidence highlighting that this can induce para-inflammatory events. So that's something that we have to keep in the back of our minds as well. So I think really the question there becomes, what is the trigger point? And one can be, for example, when do we know that a patient is really not going to recover their counts in the foreseeable time? Some previous data that we published highlighted that patients that have what we call an aplastic phenotype, so that means that they have less than 500 neutrophils for more than 14 days. These patients actually have, in median, a very, very long time period of neutropenia if you don't treat it effectively. So these might be candidates where it makes sense to sort of apply that bag if you have it in your back pocket.
Okay.
Now, the other aspect is, and I think our survey really highlighted that investigators think that this is an effective strategy. Now, only 10% of investigators reported doing a prophylactic collection. So what does this mean? This would mean that you're preparing a patient for CAR T-cell therapy, and you're anticipating that this patient may develop cytopenia. And so what you're saying, okay, let's think about this. Why don't we collect some cells, apheresis the CD3, freeze them away, and then if a patient develops this sort of side effect, let's give it back to the patient. Now, that is a bit of a more difficult story because you really have to think about how many patients actually develop sort of life-threatening cytopenia. It's probably, less than 20%, probably even less than that at this point now as we move sort of into earlier treatment lines. It is unclear what the number needed to treat is for prophylactic stem cell collection, because you may be collecting stem cell for patients that never develop clinically relevant cytopenias, and you've gone through the entire hassle. Now, what are the downsides? I think that this is really important to highlight. If you do it, you need to be able to realize this supportive measure in a very timely way that you don't delay treatment. Because if you're basically collecting cells, you're giving a patient chemotherapy or bridging therapy, then collecting the cells after that. If this in any way or form delays your application of CAR T cells, that gives the lymphoma, the myeloma time to sort of gain steam, which is really something that we don't want prior to CAR T cell therapy. So again, it's this sort of risk-benefit weighing. And then also just clearly logistics and costs. So in resource-intense settings, this might be a feasible strategy. But if your number needed to treat is to prevent one sort of very severe side effect, that still may be something that's not feasible in certain healthcare environments and certainly not cost effective. So I think that those are sort of the guiding principles. The clinical aspect being that you really don't want to delay that time period to CAR T cell application. You don't want that collection of stem cells to delay fundamentally your application of CAR T cells.
So if I follow that, you've got all this data, and then you actually then met for 2 days in Lille in France. For those of us who don't know where that is, it's in the north of France near the Belgian border. I think it was part of Belgium a long time ago.
I'm sure the French like to hear that.
Yeah, so I should be careful. I think the name for Lille in Dutch is at Azel, actually, because if you travel across Belgium and you're going towards Lille, the signs start off in Dutch and then they change to French, and you think you're going to the wrong town, but actually it's the same place with 2 different names. Anyway, so you had this great meeting in Lille. I don't know how many there is, but you can tell us. And then you published this, mentioned the paper in Blood, which is now actually the framework for consensus grading and best practice recommendations. And this includes this nice treatment algorithm for immune effector cell-associated hematoxicity. So how challenging, you had all this data from the survey, how challenging was it to move from that survey to the recommendations? What was the room like? Was there big debates? Was there arguments on what the consensus was? And was it like herding cats to get to a point where you all agreed and then there were some naysayers? So
sounds much, yeah.
And of course, the anecdotal evidence would be then, once you've got that out there, have practices changed? Have you managed to get to that far? So
maybe we can go back to that question sort of at the end, but I think just sort of going back to sort of the story of ICAHT, which just for the audience, if you want to pronounce it correctly, imagine a cat holding an iPhone. That's the ICAHT. That's the way to do it. There's a really great PowerPoint slide by Dr. Frederick Locke from the Moffitt Cancer Center. I think once you see it, you can't unsee it. I don't think that you mispronounce it. So really the story behind it is that we were actually sitting in an office with my mentor, Professor Subkleve, also from the LMU in Munich. We were really thinking about, even before the survey, we were really thinking about these cytopenias, and we had observed perhaps, some degree of recency bias there as well, but we had observed some very profound courses of sort of treatment refractory bone marrow aplasia, essentially secondary bone marrow failure after CAR T-cell therapy. And these cases, to a certain degree, were tragic, and they really prompted us to think about this question as a whole and really, again, get data together, and sort of led to sort of multi-center analyses where we tried to really understand the patterns of hematotoxicity that are observed. And we had the feeling that there was just a high degree of heterogeneity. And so when we reached out to EHA and EBMT to start and initiate this effort, really the survey, I think, was a great starting point, because it just confirmed that sort of thought that we had, which was, okay, people are saying this is a problem, but when we answer a query, there's a lot of heterogeneity in terms of grading. There's a lot of heterogeneity in terms of diagnosis. There's a lot of heterogeneity in terms of treatment. And so those are the ingredients for then really saying, okay, well, this is actually somewhere where we can, get together, sit down, and think about how can we address this. And so we got together essentially a panel of experts from EHA and EBMT, really fantastic colleagues. Some have become friends. I can certainly say that, which is just this vibrant environment that we've have in Europe in hematology, which is just absolutely fantastic, and EHA is a big part of that, EBMT as well. But we essentially said, okay, we need to sit down. And we have to think about this and get in a room, and it's not very sexy. It's a room.
But how many people are we talking about? Is it 10, a dozen,
20? 20, 30. Okay. We had working groups before, so we really tried to set it up. And there, again, the EBMT process was really helpful here, because we were able to set up, but even before the meeting took place, we had multiple sort of breakout sessions. We had different groups that had met virtually before. Some people never were able to make it in person, but they had already provided their feedback and expertise. And so when we got to Lille, we already had sort of a general structure in mind as to sort of what the thematic frame would be. We knew that we needed to develop a grading system, and that would be probably the largest challenge. And that was it took almost the whole first day, just discussing and thinking about different ways that we may be able to grade. One sticking point was, do we grade just neutropenia? Do we grade anemia and thrombocytopenia as well? And initially, I think it was felt that the most treatment recommendations were derived from neutropenia. So we really followed in on that, although some recent evidence also highlighting that thrombocytopenia is very relevant as well. And that'll probably be incorporated moving forward, really highlighting that this is a dynamic field. Again, I really want to highlight this. This is not meant to be the definitive grading system. It's supposed to be something that's fluid. As we gain more knowledge, as we gain more information on how different disease populations, patient populations develop this side effect, we will learn more, and we will be able to adapt it as well. But so really the grading was difficult, because we had to think about, what do we use to define early versus late. We wanted something that is very clinically relevant, particularly for the early phase. But we also wanted a grading system for these prolonged courses. So that's what we call now late ICAHT. But the intent of late ICAHT is really almost, to a certain extent, more to just capture the event happening. So there's almost a duality there, where the early ICAHT is really meant to derive clear treatment recommendations. And sure, if a patient, still is in that algorithm by the time they hit day 30, we continue with the algorithm. But the late ICAHT is more meant to sort of just characterize these cytopenias occurring in the first place, because there's no reason why a patient receiving fludarabine, cyclophosphamide lymphodepletion, and then CAR T cells should have any type of neutropenia at day 30, right? That shouldn't be happening. And so we wanted to capture these events, these sort of protracted, prolonged courses, but at the same time have something that's really clinically relevant in that early phase. And so we derived our thresholds from essentially our infectious disease colleagues. So we really tried to gain knowledge from them and think about, okay, what is the clinically relevant neutropenia that's observed? And we know that there are certain thresholds that are just associated with higher incidence of infectious complications for neutropenia. And so there are these thresholds that were defined by ASCO and IDSA, so the Infectious Disease Society of America, where you basically understand that there's severe neutropenia, which is an ANC less than 500, and profound neutropenia, which is an ANC less than 100. That's the previous CTCAE grading only goes to an ANC of 500. And so we thought that that was insufficient. Should be noted, though, literally this week, the new CTCAE grading came out, and now actually neutropenia grade 4 is actually an ANC less than 100, which is actually the exact same threshold that we use.
Okay.
So perhaps prescient, I don't know. But essentially, we really derived that from the infectious disease setting because we felt that an ANC less than 100, essentially an ANC of 0 is not the same as an ANC of 480.
Yes.
And so our thought process here was that if you have an ANC that's essentially 0, meaning you have no neutrophils for 7 days, we just know from our infectious disease colleagues that that's associated with a very high risk of infectious complications, particularly severe bacterial infections, also fungal infections. And so our trigger for the profound category, so an ANC less than 100, was once you hit 7 days, you're at a very high risk for infectious complications. We know this to be true based on hard data that's out there. And so that for us was grade 3. Now you'll see that in the grading system, an ANC less than 100 doesn't give you grade 1 or 2 because we basically said we want this threshold to basically define a severe hematotoxicity event. Whereas for the ANC less than 500 threshold, you needed to have it for a certain amount of days. Now, I think some of the evidence that has come out since we've developed this grading system, I think has really emphasized that we looked at this in a cohort of more than 500 patients. There's a very strong association between ICAHT grading, early ICAHT grading, and infectious complications. So I think what this demonstrates is that if you go a step back, you want to develop a grading system that's clinically relevant. Think about what is the complication that is most feared and that you want to capture with this grading system. And then try to develop your grading system around that. I think that that's sort of the approach that we had, while still having this general idea that a grading system needs to capture things. And so that's where I would say the late ICAHT, the functionality of late ICAHT is that it captures the events happening in the first place, whereas the early ICAHT really, I think, wants to capture those clinically relevant infectious complications due to neutropenia, and then also derive management recommendations. That was a really key aspect as well, that we can say, well, if you have this, then do this.
Yes.
And you'll see in the guidelines document that a lot of time is then also dedicated to diagnostic studies. There's a whole working team that just worked on this. I just want to highlight Marie-José Caston, Catherine Tiblemont, who did a really fantastic job here, Rafael Greco, and others who really tried to think about what would be the diagnostic studies, and then really also treatment recommendations. A lot of people really thinking about what are our best practice recommendations currently before and after the meeting, really going into the literature and trying to discern the evidence-based for our current treatment recommendations. Again, recognizing that this is likely to be fluid. And as we gain new information about management strategies, perhaps the next iteration of this document may look perhaps a little bit different. And I think that that's a fantastic thing.
I agree. Just to kind of wrap up the podcast now, and both your survey is out and the follow-up kind of guideline and blood has come out with the associated commentary, which I really recommend listeners to go and check out for the grading system. I know we're talking about HemaSphere, but we can talk about other journals as well. And the commentary is from David Qualls and Karen Jacobson, and they've got a nice figure which actually shows the early ICAHT versus late ICAHT and color-coded, and then also the management considerations. And I was checking that out today going, oh, that's a very nice illustration of what you're talking about, capturing that data. And then also below that line, it even gives them some management consideration. Obviously, this is a great paper. I mean, you're extremely passionate about that. It's coming through. Has been the outcome of this? What are you most proud of? What's the next step? And have you gone back to the centers and seen if your guidelines actually has changed practices?
Yeah, I mean, just from a personal side, I think that this was one of the most rewarding things that I've been a part of, just being able to really think about identifying a clinical problem, thinking about pressing needs, and then moving towards sort of a guidelines, a document, and thinking about how we can implement changes. I think that's sort of just something that's really rewarding to be a part of, and to be a part of it with immensely talented colleagues, mentors, and others who I think were just very supportive along this process. I would just encourage anyone listening who is perhaps still sort of a trainee to really find your mentor and find people who empower you to sort of go after it and try to sort of address clinical problems. So I think that just from a personal note was very rewarding. And I think we've really tried to follow up ICAHT as on the grading system. We've tried to follow up on it also in terms of understanding pathophysiology. Because if you think about where are the unmet needs moving forward, I think we still need to understand parts of why patients develop these side effects, like understand it in the lab. And so, for example, we published a paper in Science Advances where we looked at these different phenotypes of neutrophil recovery that are observed. We see that there's actually really foundational biologic differences between these phenotypes. Looking at proteomics, we see that there's sort of a really inflammatory milieu that's already present prior to CAR T-cell administration in the patients that go on to develop this sort of side effect. We've tried to develop predictive models, mainly a model called CAR HematoTox, which has been developed in Munich, which has now actually been implemented clinically in many places because we essentially were able to show that high inflammatory markers, so CRP and ferritin, as well as hematopoietic markers such as ANC, platelet count, and hemoglobin, that these are actually very closely associated with the development of sort of clinically relevant cytopenias. So hopefully moving from understanding the pathophysiology even better, trying to really use novel techniques, model it in vivo settings, murine models and others, to really understand what is going on. Because I think what we're still lacking, and I think that that's sort of one of the things that's perhaps the largest unmet need, is better treatments. Right? We talk about giving GCSF, and GCSF is almost like a Band-Aid, right? You can shorten the period of neutropenia, but a patient can be neutropenic for 3 days and develop a very relevant infections also, right? So to a certain extent, I think there we still have to do better. We have very effective treatments with sort of stem cell boost. I think we, as a field, agree that that's an effective treatment strategy. Although, again, some recent evidence perhaps cautioning this as sort of a treatment for sort of all settings, because there may be some downsides as well. But I think understanding more foundationally what is going on and why CAR T-cell patients are developing these cytopenias. Also, how relevant are these? Where do they derive their clinical relevance? For example, in this sort of translational paper that I alluded to, we showed that patients that have biphasic cytopenia, so they have sort of this intermittent pattern. They drop their counts, recover, and then they drop again. At least in the lymphoma setting, interestingly, what we found was that these patients actually have superior treatment outcomes, higher CAR T-cell expansion, which is sort of very fascinating to a certain extent, understanding what is going on. What is the interactions between the host hematopoietic system, the CAR T-cells, and the lymphoma? What is going on there? Understanding that better, I think, is just biologically very interesting. And so I think that there's still a lot to learn, but hopefully by learning what is going on more foundationally, we can move towards more effective treatment strategies. And then the last thing that I'll say is that when we're applying CAR T cells in the third, fourth, fifth line, as was the case sort of early on, these patients, they had really battered bone marrows from multiple lines of chemotherapy. At least what we're seeing, I think, again, we can learn from other settings as well. CAR T cells are now being applied in the rheumatologic space. The degree of cytopenia seems to be a lot less pronounced there. And so, that's something that I think we have to think about as well. What about chemotherapy-free sort of conditioning, right? I think that there's a lot of
the ultimate goal, yes.
The ultimate goal. In vivo CAR, right?
Yeah.
So
reprogramming in vivo, yes, exactly.
So there's still a lot of exciting areas, I think, where we can get better. And I do think that as we move CAR T cells into earlier treatment lines, at least the hematopoietic compartment will be less battered. As in a patient that has received 7 lines of chemotherapy, you can imagine what that does to a bone marrow. And so at least there is some degree of hope that as we move these treatments into earlier lines, the degree of hematological toxicity will be less pronounced. And the good thing is that we now have a grading system in place that will help us objectify if that happens. Because now we can say, look, the incidence we know grade 3 ICAHT, early ICAHT is clinically relevant. And this incidence has dropped significantly from third line to first line, or due to this sort of supportive measure. So I think that's where I probably end it. A lot of exciting things to learn. Personally, very rewarding to be involved. And I really just want to highlight that this is the paper, but again, the work behind it, a lot of fantastic colleagues that really were privileged to work with, Ana Zureda, Ibrahim Yaqub Aga, my mentor, Marian Zubtiv, and others. But, it takes a village to develop something like this. Certainly, it's not sort of just something that we developed in our backyard. Trying to build consensus means that you try to hear a lot of disparate opinions and that you use that heterogeneity in sort of surveys as sort of a starting point, as something, hey, this is a great challenge to work towards. And I think that's sort of where this HemaSphere paper
where the magic
derives
derives
its benefit.
And I think your point saying that these aren't set in stone, these guidelines. They are always going to be fluid. As practices change, they should be changing as well. But this is a great starting point. And I love how you said, we've got the grading. We can now track that grading, how it changes over time. And I think that's going to be a massive change for the way that we treat these patients. So, Kai, thank you so much for your time. Congratulations again on the award for the most cited clinical paper for HemaSphere, and all the best with your work. And I look forward to maybe in a couple of years we meet again and talk, or it's someone else who's, and you're the mentor and you have a mentee who's going to drive the next set of guidelines. So congratulations and thank you.
Thank you so much.
Thank you for listening to this episode of the HemaSphere podcast. All of HemaSphere's content is open access and can be found at www.hemispherejournal.com. We hope you will join us for future podcast episodes.